Hi, everyone. Thanks for joining us today for this webinar on OCD in children and the impact of COVID-19. My name is Emily Scahill. I'm the Manager of Public Education and Awareness at MHA's National Office, and I will be moderating today's webinar. Some notes before I introduce you to our presenter today. All participants are muted and unable to turn on their microphone. We are recording this webinar, and I will send that out to everyone along with the slides early next week. And we do not offer CEUs, but we are happy to provide a certificate of attendance upon request. I'll post the link to request that in the chat, and I'll follow up and in the follow-up email next week as well. And last but not least, we've built in some time for a Q&A at the end. So drop any questions in the chat throughout the presentation, and we'll go through those at the end. And feel free to use the chat box now as well to let us know where you're from, or pop any comments in there throughout the presentation. And now I am so excited to introduce today's speaker, Denise. Denise Egan-Stack is a home-based cognitive behavioral therapist who has been treating children, adolescents, and adults with OCD and anxiety for over 20 years. She has been involved with the International OCD Foundation since 1998 and currently serves on the board of directors and the Scientific and Clinical Advisory Board. She is co-writing the IOCDF website, Anxiety in the Classroom, and helps plan the pediatric programming at the annual conference. In addition, she has trained professionals nationally and internationally on evidence-based treatment for OCD. And with that, I will turn it over to Denise to get us started today.
Thank you for the introduction and for having me here today. It's wonderful to be here and to have so many people joining from across the country. It's very cool. Welcome. Right now we have 623 people, so I love it. So I'm excited to talk to you guys today about obsessive-compulsive disorder in children, how it affects families, and the impact COVID has had on youth with OCD. As mentioned in the introduction, I have been a part of the International OCD Foundation now for over 20 years. And for those of you who are unfamiliar with the organization, I want to just take a minute to introduce you, because if you're here because you're interested in OCD or learning more about OCD, you're really going to want to know about the foundation. So the International OCD Foundation's mission is to help people living, struggling with OCD to live full lives. And the OCD Foundation does this by bringing together people living with OCD, their families, their friends, their supporters, and professionals and researchers in the field. And they build a sense of community through events like the annual OCD conference. They host awareness raising events that fight stigma. They train professionals and treat OCD, and so much more. And the foundation's reach is very wide. And that includes about 1 million people who go to the website every single year to learn more about what the IOCDF does. And if this is interesting to you or you want to learn more about it, you can do the same thing by going to IOCDF.org. It's a very cool organization, and I'm really proud of the work that it does. So with that being said, let's move on to today's topic, OCD in children. So when we're working in this area, we really need to differentiate between the developmentally normal and appropriate fears that children experience and the routines that they develop from the obsessions and the compulsions related to OCD. Okay, so here on this slide, you see that we've listed fears children experience at specific ages. Again, these are normal, and they're associated with minor avoidance and minor discomfort and generally pass with time, right? So in the first years of life, kids have a fear of loud noises, strangers, new places and heights. But again, that there's minor discomfort there's minor avoidance, and they'll pass with time. Children also develop routines as they grow up. For example, at bedtime, kids might want to be tucked in a certain way every night, or they might line up their stuffed animals in a certain way every night, or they might say goodnight the same way, like, hey, don't let the bed bugs bite, right? Or at mealtime, they might have a certain chair that they want to sit in, or they might, eat the same breakfast every morning. And these are normal routines. They're associated with enjoyment, like kids like them. They're fun for them. They don't take up a lot of time, and they can be stopped at will, okay? So normal fears, normal routines. The form and the content might be the same as an OCD obsession or compulsion, but they differ in the frequency, intensity, and the feared outcomes. Okay. So if your child has fears or routines that are very frequent, they're happening over and over and over, they're very intense, they're very fixed, they're very rigid, they're scary, they cause a lot of distress, then there might be a bigger problem there that you want to get checked out with a professional. Okay. And so one of the things that might be is OCD. And in order for a child to be diagnosed with OCD, certain conditions need to be met. And I have them listed here. Um, you know, in the Diagnostic and Statistical Manual, the latest edition, which is the manual that we use in psychology to diagnose people, it says that, people need to have obsessions or compulsions. But to be honest with you, in over 20 years of doing this, I've never really seen a case where there weren't both obsessions and compulsions. And obsessions they're intrusive and unwanted thoughts, images, or urges that occur over and over again, and it feels like it's outside of the child's control. So these obsessions are unpleasant for the child and typically cause lots of worry or anxiety and distress. Okay, so obsessions make people anxious. They are thoughts, they are impulses to do things, they're images that happen in someone's mind that are really distressing. They cause a lot of distress, a lot of anxiety. Compulsions, we also call them rituals, are behaviors that children feel they must do with the intention of getting rid of the anxiety that the obsessions create. Okay, so the child might also do these because they think that somehow engaging in the behaviors or the rituals will prevent something really bad from happening. Okay, and so an OCD diagnosis will be warranted if there are obsessions and compulsions and they're so time consuming that they really impair a child's day-to-day functioning. So what's a child's job? A child's job is school. So if OCD was impairing school, causing, distress or, preventing a kid from being able to function well at school, it might look like they don't go to school anymore, or they're chronically late. Every morning they're late, they're coming in late because of rituals that they have in the morning. Their grades may drop. They may be handing in homework late or doing homework or never handing it in. They might spend most of the time in the nurse's office because they don't feel well. A child's social life might also be impaired. They may no longer be able to have play dates or sleepovers at their own home. They might not be able to go to sleepovers or play dates in somebody else's home, or they might drop friendships altogether. Also, the way a child takes care of themselves might change. They might shower frequently, like 2 or 3 showers a day that are very long, or they might not shower at all. They may have to change their clothes multiple times a day, or they might not change their clothes at all. So you have the obsessions, you have the compulsions. They have to be time consuming and cause distress in a child's life in the ways that I just said. Okay, there's 2 things I want to note right now. Let's go to, so common obsessions in children. So these are sort of the classic ones. These are the things, again, the thoughts, the images or impulses that make people anxious. Here are themes: fear of dirt, germs, or serious illness. That's sort of contamination. Fear for personal safety, like they're worried that something bad is going to happen to them, like they might get kidnapped. Or fear of safety for their parents. They think their parents might die in their sleep or get hit, by a car or get in a car accident. They have feelings that things have to be just right. And if something is not just right, then they'll feel so much anxiety, they won't be able to cope. They'll never feel right again. Or they may have disturbing and unwanted thoughts or images about hurting others. They may have an image of picking up a knife and stabbing their younger sister, whom they love very much. Or they may have images of acting sexually inappropriate with animals or, their siblings. Okay, so these are the obsessions make people anxious. These are some common compulsions in children. So if someone has the obsession that they're contaminated or they're afraid of getting sick, then they're going to, the compulsions that makes them very anxious, the compulsion that they would do to feel better might be excessive washing. So they might wash their hands multiple times, multiple pumps of soap for, a long period of time. Also, children touch or tap things a certain number of times. Sometimes it's to ward off something bad happening. There's excessive checking. If they were afraid that something bad was going to happen to them, that maybe someone was going to come into their house and kidnap them at night, before bed, they might do excessive checking of locks or window locks. They might count to a certain number of times to prevent something bad from happening. If a child has the obsession of things needing to be just right, causes them anxiety, then they're going to do things over and over and over until it feels just right. So that might be putting on a pair of pants over and over and over again, or saying the same thing over and over and over until it feels quote unquote just right. They might order and arrange things in a certain way. So, a normal routine for a kid might be, like I said, to line up stuffed animals before bed. But an OCD ordering and arranging compulsion would be that the stuffed animals had to be lined up over and over until it was just right. And it would be very intensely done, very rigidly done, with lots of distress, maybe some tears and fears that, they're really trying to prevent their parent from dying in the middle of the night. And so it's really imperative that they get these stuffed animals lined up just right. Kids might confess or apologize. I'm really sorry that I had that thought about stabbing my sister, or I just want you to know I just had that thought. And they'll do it over and over. They might ask for reassurance. Am I okay? Am I going to be okay? Are you okay? And they'll ask for it over and over and over. One answer is never enough. So these are all things that kids do to feel better. But there's also things that kids avoid so that they don't get anxious. So they might avoid touching doorknobs. They might avoid taking a shower. They might avoid going to school. They might avoid seeing people. So they're not doing certain things to feel better. Okay. And so there's two things I want to note about obsessions and compulsions. The first one is that sometimes kids are very forthright about what's going on with them. They'll say, like, I'm having these weird thoughts. I don't like them. They make me anxious. I'm having to do these weird behaviors. Help me. And I'm sure for parents, the first time they're hearing this, it could be somewhat distressing, but it is good news that the kids are open and honest about what's going on with them, because then we can actually do something about it. But there's also a lot of kids who are not so forthright. They're embarrassed. They feel ashamed. They feel crazy. They think other people are going to think they're bad. How could you ever want to stab your sister? You must be a terrible person. And so those kids might not come forward with this information. And so that can really lead to confusion and misunderstandings and a delay in getting a kid into treatment. And so sometimes kids will tell you and sometimes they won't. And you might just have to look at the distress in their life, the change in their social relationships, the change in their academic performance as a way to clue you in on the fact that something might be going wrong. The second thing I want to note, especially with compulsions, is that some things you can see, right? Like you can watch your child washing their hands over and over. You can see their hands chapped and bleeding or swollen, or there's way more, paper towels that are gone and like the soap, we're flying through the soap. What's happening here? Or, a child's asking you for reassurance. But there's some things that happen, compulsions that are happening in a child's mind, in their head, like counting or praying. And so you might not really know what's going on, but it might look like they're daydreaming or they're very distracted. So that could be a clue that they're engaging in compulsions. And so I just wanted to note that. Okay, so we went through the diagnostic criteria, reviewed what some common obsessions and compulsions are. Let's talk about how frequently pediatric OCD occurs. So about 500,000 children in the US suffer from OCD. That's about 1 in 200. This means that in an average size elementary school, there might be 4 or 5 kids that have OCD, or in a large size high school, there might be about 20. And research suggests that, about half of all cases of OCD have had a pediatric onset. And pediatric OCD appears to be more common in males than in females when compared to adults, where that ratio is, more like 1 to 1. Okay. Okay, so what causes OCD? Well, to be honest, we don't still have the exact cause or causes of what, of OCD, but research does point us in a couple of different directions. The first one is the brain. Brains of people with OCD are different than brains of people without OCD. And so research suggests that OCD involves problems in communication between the front part of the brain and deeper structures in the brain, okay? And these brain structures use a neurotransmitter called serotonin. And in some people, the brain circuitry will become more normal when they're taking medication that affects serotonin, or the brain circuits become more normal when they're engaging in cognitive behavioral therapy, which is the treatment for OCD, okay? So there are brain differences. The second is, there's an infection-based OCD, and it's called PANDAS when the infection is strep throat, and it's called PANS when the infection is something else like mono. And basically what happens is the immune system, instead of attacking the infection, attacks the brain, and it creates, OCD symptoms. And one of the hallmarks of PANS or PANDAS is an literal overnight symptomatology. So on a Monday, your kid could be fine and completely normal, and by Tuesday or Wednesday, they could be riddled with OCD symptoms. And oftentimes these OCD symptoms are accompanied by extreme separation anxiety, bedwetting, and anorexic behavior. Okay, and so if you have a child and you felt like overnight they went from completely normal to being riddled with OCD, you'd want to take them to the pediatrician and have them tested for strep or other infections. Okay, and then the third is OCD appears to run in families, which suggests a genetic link, and that could be possibly up to 50% of cases. So people are predisposed to having OCD, right? So there's differences in the brain and there's differences in genetics, and those differences make them vulnerable for developing OCD. Okay, so what's the clinical presentation? So OCD symptoms tend to have a gradual onset. That means that they develop over the course of several weeks or months, unless, of course, we're talking about the infection-based OCD I just told you about in the last slide. And OCD honestly can start at any age. I mean, it could start from any time between preschool to adulthood. With that being said, there are generally two age ranges when OCD tends to appear first, and the first is between ages 8 to 12, and the second is between the late teen years and early adulthood. And when we talk about the course of an illness, what we're talking about is the behavior of an illness over time. And with OCD, there are two courses. There's a chronic course and an episodic course. And a chronic course means that even though symptoms might wax and wane, there's never really a time in a person's life when they don't have OCD symptoms. They never get a break. They never fully get a break. And an episodic course means that symptoms occur in like discrete periods of time, right? So in between those periods of time, the symptoms are in remission. And so people who have PANDAS or PANS, they have episodic courses of OCD. Let's see. So OCD can sometimes occur all alone in a child, like it's just they have OCD and nothing else. But oftentimes, other mental health conditions occur at the same time. And some of those are depression, ADHD, tics, or other anxiety disorders like separation anxiety or social anxiety. And for the most part, kids with OCD or people with OCD will say that the content of their obsessions and compulsions change over time. So they always have obsessions and they always have compulsions, but the content can change almost like whack-a-mole. I was talking to a kid that I work with. I was speaking with him today before the presentation, and just in a matter of overnight, some of his obsessions and compulsions went away, but new ones came up, right? So they're always changing, and that is incredibly frustrating for people. Okay. So let's talk about OCD and COVID. When COVID first started, tons of people asked me, like, would all of this hand washing cause OCD? And, the answer is no. No, COVID does not cause OCD. I mean, individuals who are not predisposed, like that slide we talked about, the causes of OCD, if people are not predisposed genetically or biologically or, neurologically, they're just not going to develop OCD because of the pandemic. Okay. There are some people who are predisposed, and the pandemic may cause the vulnerabilities may be exploited by the pandemic, and they make, that might cause OCD to show up. But people who are not predisposed will not get OCD because of the pandemic. Okay. However, there are many people who have been super anxious about the virus, right? Like anxious about washing hands, wearing masks, social distancing, washing off packages before they come in the house. But for these people, their behavior is going to go back to normal after the pandemic is over, right? So once the threat is gone, their behavior goes back to the way it was, versus OCD. Okay. When the pandemic is over and the threat is gone, the behaviors, the obsessions, the compulsions still stay the same. Okay. Now, there are some people, I guess people asked me another question when COVID first started, like, not only did they say, is all this hand washing going to cause OCD, which the answer is no, we just went over that. People also said, like, how's your caseload? Everybody must be going crazy. Their OCD must be off the charts. And again, my answer was not necessarily, right? There are some people who have a symptom type that is really directly related to the pandemic, right? COVID. So people with contamination, or the fear of getting sick, the fear of causing harm to other people, or perfectionistically wanting to make sure they're washing their hands perfect, or they're perfectly 6 feet apart, or, have the perfect mask. Those are my folks who, if they were doing very well in OCD treatment, maybe even in remission, they may have had a lapse or a relapse, or their current symptoms may have gotten worse. But, for other people with OCD who do not have these symptom types, they're actually doing quite well. I actually had someone say to me, Denise, this is what we train for, right? Because people with OCD in treatment have learned how to sit in discomfort. They've learned how to sit in, tolerating uncertainty. They've learned to live a life with this impending sense of doom. And so I think they're, faring quite well and much better than maybe the general population. Okay. So that is an overview of, sorry about that. Moving forward. Okay, so that is that's an overview of pediatric OCD and how COVID has affected people with OCD, kids included. But when we're talking about OCD, we really always have to talk about families, I think, because families are almost always, if not always, involved. Okay, because living with a child with OCD can be incredibly challenging. It's really difficult to watch someone you care so deeply about suffer so much. As we discussed, the anxiety is debilitating, the rituals are very time consuming, and the impact OCD has on their life can be devastating. Okay, they're dropping out of school, or they've lost their friendships, or, they're showering constantly, or, they can't touch the gaming computer that they spent so much time building. And it's really hard to watch. Parents just want their kids to be okay. They just want their kids to feel better. And the attempts to help by assisting with the OCD is called family accommodation, okay? And again, it's just intuitively wanting to help, intuitively wanting your kid to feel better, but the ways in which you're trying to help can unexpectedly result in more anxiety and frustration instead of less. And oftentimes you find yourself entangled in the OCD symptoms instead of assisting your loved one out of them. So this pattern is incredibly common, and this is why I always want to talk about family involvement. In fact, studies show that family accommodation occurs in 60 to 97% of families, okay? And that a lot of times it happens on a daily basis, okay? So we want to talk about, in the next part of the presentation, we want to talk about, just kind of tease this whole thing apart. We'll talk about how what the common accommodations behaviors are, why accommodation doesn't work, and what to do instead, because everybody wants to know, well, if what I'm doing doesn't work, tell me what to do instead. Okay, so on this slide, we have examples of very common accommodation behaviors. And if you're living with someone with OCD, if you have a child with OCD, I bet you these are going to sound really familiar to you. Okay, so the first is that families participate in ritualistic behavior. So families might be washing their hands according to OCD rules or under the supervision of your child with OCD. Make sure you do it right. And you have to rewash if you do not do it correctly. Families may have to say something over and over, so at bedtime, you may have to say, don't let the bed bugs bite, over and over and over until the child feels like you've said it just right. You may have to clean a certain way. So if a child has a fear of chemicals some of which are underneath the kitchen sink, if a family member touches the kitchen sink knobs, they may have to wash their hands. They may not be able to touch the refrigerator door or the microwave door or the countertops. Okay. Another example of family accommodation is families who assist in avoidance behavior. Remember, I said not only do people do things to feel better, they sometimes refuse to do things so that they don't get anxious. So family members might not drive past cemeteries, or they might avoid saying certain words or certain numbers or singing certain songs. Family members oftentimes make decisions for children. If children have a fear of making a mistake, they might not want to decide, and families will do that for them. Sometimes families even speak for their children. I remember one person I worked with who, for the first 2 sessions, she just wouldn't speak to me. And it wasn't selective mutism, it was related to OCD, and her parents had to speak for her. Okay. Another way that families accommodate is that they facilitate symptomatic behavior. So sometimes people with contamination fears or kids with contamination fears will throw away all their clothes if they think it's contaminated, or their phone or their bedding. And families will oftentimes rebuy these things over and over. Or they might buy excessive amounts of toilet paper if children are using tons of toilet paper in the bathroom, or cleaning products, lots of Clorox wipes. Families also modify their routines. So sometimes a child can't eat food prepared in the home. They can only eat food that's brought in from out of home. So family meal times are disrupted. Sometimes families will not eat until a child has gone through an elaborate prayer routine, like saying grace, but very OCD elaborately and time consuming. After school, sometimes, kids or family members, or after work, have to come into the garage and strip down naked and then go take a shower immediately. Okay, so these are all ways in which just regular family routines can be disrupted. Sometimes people with OCD are not able to contribute in any way to the household. So if the siblings or if the kids in the family have responsibility for the dogs, and one of the children with OCD can't do any of it, the rest of the siblings, their brothers or sisters, might have to do all the dog walking or all the feeding of the dog, or if they have responsibility for setting the table before dinner, they'll have to pick up extra slack. And if there's an adult in the house with OCD, then sometimes the other parent has to pick up all of the cooking or the grocery shopping or the child rearing. Okay. Offer excessive and repetitive reassurance. We've talked about this. So morning routines, bedtime routines, just anytime during the day, family members find themselves having to answer the same question over and over and over. Modifying leisure activities. Like I said, sometimes kids with OCD don't really want anyone in the house other than the family because they can't control that person, or they don't want the person to see the ways in which their rituals, take place during the day. So sometimes people can't have, relatives over for birthdays, or can't host holiday celebrations, or siblings can't have friends sleep over. Interference with work functioning. So lots of times, parents might, if their child is having a hard time going to school on time, going to school at all, parents can oftentimes be late for work or have to call out excessively for work because they can't leave their child at home, or they don't want to leave their child at home because they're in such distress. Or children might text their parents constantly, I just want to tell you I had one of those thoughts about stabbing my sister, or I just want to make sure you're okay. Did you get to work okay? Are you okay? Did you eat lunch okay? Any choking? And so parents are constantly checking texts or having, phone calls to work during meetings, and that can really interfere with work. So these are some examples of family accommodation. And like I said, if you're living with someone with OCD, I bet you some of this stuff sounds pretty familiar. Okay. So, we said 60 to 97% of families engage in family accommodation, but research shows us that, it's not really all that effective. 80% of family members believe that the obsessions and the compulsions are not really reasonable, that this stuff doesn't really have to be done. And 60% believe that even when they do it, it doesn't really help at all anyway. So why do we keep doing it? Why do we keep doing it if it doesn't really work? Well, in the short term, it does work. It gets the OCD sufferer out of that really hard moment. And like, that's phew, now we can just move on. Like, it reduces family disruption. So if you can just do what you need to do to get your kid to school, then I can get to work, parent can get to work. If you just do what you need to do to get through the prayers before dinner, just let him do what he's got to do, then everybody can eat, right? If you just do what needs to be done to get him to fall asleep, then parents can get a break. So it helps the OCD sufferer in that moment, and it also reduces family disruption. So in the short term, it really does work. But in the long run, it does not serve anybody well, because it can actually make things worse. It's not only that it doesn't just help, it can make things worse. So research shows us that family accommodation can contribute to greater OCD severity, poorer patient functioning, and increased family discord. Okay, so in the short term, it works, but in the long run, it doesn't. And in fact, it's not that it doesn't just not work, it makes things worse. Okay. Okay. So let's talk about why it doesn't work. So accommodating behaviors interfere with learning new information on the part of the OCD sufferer. So if we're always swooping in to get rid of that tough moment, the person with OCD is not going to learn a couple of very important things. Number one, they're not going to learn that if they resist the rituals, their anxiety might come down on its own. They're not going to learn that, it's the anxiety isn't quite as bad as they thought it was going to be. Or if it was pretty bad, they're not going to learn that they were able to cope better than they thought they were going to cope. They're not going to learn that the anxiety doesn't last as long as they thought it was going to last. And they're not going to learn that they actually feel very powerful and very brave when they stick up to OCD. Okay? So when we swoop in and when we take care of business just to get your child to bed, which of course you're going to do. I mean, I would do the same thing. When you swoop in to kind of get rid of that distressing moment, we really rob the child, or anybody with OCD really, from learning those really important things. Also, family accommodation is usually done with resentment. Families usually vacillate between accommodating the OCD and losing their patience. Families get tired, angry, and resentful, and there's lots of criticism, and who can blame you, right? And research shows that kids whose parents are more critical have poor functioning even after treatment. Okay, so a lot of times people are just burnt out, they're exhausted, they're tired, and even though they're washing their hands, or even though they're saying the prayers, or even though they're saying for the 20th time, don't let the bed bugs bite, it's oftentimes done, like I said, with anger, hostility, resentment, and criticism. Okay. So accommodating the family member might be with the intention to keep the peace. However, the solution is short-lived as the anxiety returns and the need to accommodate arises again. We just kind of talked about that. It's a cycle. It is a vicious cycle. Okay. And clients with OCD report that the accommodating behaviors are usually not all that helpful anyway. So when they're asking that question, like, do I have HIV? How do I get HIV? They're not really interested in learning about the ways that you get HIV or COVID. They're really just asking that question over and over and over until so that they can feel better. So they know that it doesn't even help that much anyway. Okay. So here I just want you guys to look at this graphic. It is a graphic that was created by Dr. Aureen Wagner, who is a pioneer in the field of pediatric OCD, and she wrote a book called Up and Down the Worry Hill. And I love this graphic because it just kind of shows you what happens when you interrupt the cycle of, like, the we're going up the hill. We're like pedaling up a hill, right? It's super hard. And once you get to that very top, the top of the hill, and you're going to go down the hill, you just kind of coast. That's where all the good stuff happens. The wind's in your hair. You don't have to pedal anymore. You know, the hill is sort of doing all the work for you. And that's really what we want the kids to do. We want them to be able to resist the compulsions to go down the hill so they get all of the good stuff. But what happens is with the compulsions or the family accommodation, we intervene right before all that good stuff happens, and then we reinforce this pattern. Okay. So family accommodation happens. We know it doesn't work. We know why it doesn't work, but now I need to tell you what to do instead. Okay. Just because we're going to not engage in the rituals, the OCD, does not mean we do not care, right? It does not mean that we can't be present in the moment. And so one of the things we really want to do is to, make supportive and encouraging statements while not accommodating. So you're not like, oh, I can't do this, see ya. You would say, things like, I know you can beat OCD, or, you've worked so hard and I'm so proud of you. I got your back, this will pay off. You can do it. Another thing you want to do is direct your anger and frustration at the illness, not at your child, okay? Anxiety and OCD are not your child's fault. It just isn't. And it's really important that all of the anger is directed at the OCD. So, you could say things like, I'm so mad at OCD right now, or OCD takes all the fun out of things. OCD is trying to bully us right now, and I'm just sick of it. Like, I'm just really sick of it. Are you? That subtle difference makes a huge impact, because then it's you and your child against the OCD versus you against your child. You want to practice tolerating your own feelings in response to your family members' distress. You want to model like bravery-based behaviors. Okay, so you want to learn to tolerate the discomfort in the same way we're asking the person with OCD to tolerate their discomfort. Like, we want you to feel the discomfort and not engage in the ritual. Well, we can't ask our child to do that if we ourselves aren't willing to do that, okay? And lots of times, if parents can stay calm or look calm, project calm, then their child might settle down around them. But if the parent is really anxious and really upset and visibly distressed, then you could see how the child and the parent might escalate each other, okay? More involvement isn't always better. A lot of times parents have a hard time disconnecting from their kid when they feel like they're in distress. And so they want to stick around. They want to keep talking about it. They want to keep answering questions. And that doesn't help. And again, oftentimes escalates things. And so we ask parents, take a break. Go take care of something else for 15 or 20 minutes and come back and check in. But more is not always better. You want to make sure you praise small gains. Change happens over time, and every little step forward is forward and should be celebrated. Lots of times parents are so anxious for their kids' OCD to be better that they will undervalue what's already been done and overvalue what's yet to happen. Like, yeah, you made those gains, but what about X, Y, and Z? That can really hurt anyone's motivation, especially a child's motivation. You want to reinforce behavior you want more of. Like, so if a child's, showing bravery-based behavior, like cheerlead the heck out of that. And if a child is whining because you won't, give into the OCD family accommodation, ignore. And you also want to try to avoid nagging and blaming. It just does not work. Okay. The other thing you want to do is obviously you want to reduce your involvement in the rituals, in the compulsive behavior, right? So I'm betting that you're probably knee deep in some of these obsessions and compulsions, and now you want to get yourself out of it. And I think the best way to do that is to use a family contract. So you're making like an agreement with everybody in the family when you are calm and you can discuss things and negotiate things like in the right frame of mind, versus being so burnt out and angry, you just decide right there in that minute, no, I'm not washing my hands anymore. Well, that's going to invite a huge explosion. And you can do this within therapy if your child is in therapy, or you can do it on your own. And here I have a slide of a family contract I've developed and used over time. I'm not going to go through it because we don't have enough time, but you guys will get these slides and you guys can look at it in greater detail. But the point is, everything is very clearly spelled out so that everybody knows what part they're playing in this family contract, so that when someone is triggered, there is really no thinking involved. You pull out the contract and just and just use what you guys have negotiated, use the plan that you've made. And then you want to make sure that if everybody does their part, there's a reward for everybody. Like we get takeout on Friday night. Okay. So I'll let you guys look at this a little bit more when you can browse through the slides after this live presentation. Okay. Okay. Let's go backwards. I just want to get back to my spot. Okay. So more things that you want to do is you want to encourage your family member to begin picking up chores and tasks around the house. So as your child is getting better, you want to ask them to come back into involvement in the family. So again, if their life is completely tormented by OCD and they're really struggling, obviously they don't have to take the dog for a walk. But as they start to get better, you want to reintegrate them back into the household. You want to praise effort and not outcome, because really what we want is bravery-based behavior. We want approach-based behavior. We want people who are willing to feel discomfort. And, you know, if you are consistently doing that, the outcome will come, the progress will come. But we want to just praise those kinds of behavior because that is key. And you want to remember that relapses can be part of getting better. Getting better from OCD is not just this upward trajectory, like straight shot up. It is more like a jagged upward trajectory. And, you know, I don't mind when people have a little bit of a lapse or a relapse, because it shows us in treatment where we need to shore up, like where we need to adjust the plan, where we need to make some changes. And we really want to normalize lapses for people, because we do not want them to think that they'll go through treatment, they'll breathe a sigh of relief and never have to deal with OCD again. As we've talked about, you know, like stressful things can exacerbate OCD symptoms, even positive stress, like moving to college or moving from middle school to high school, or your first boyfriend, or if mom has a new baby, or you guys move into a new home, or dad gets a new job. You know, that could really exacerbate OCD symptoms and they could be a little bit of a lapse. But again, if kids are learning their coping strategies and they're making progress in treatment, this is what they train for, right? Kind of like when COVID hit, and you can just utilize your plan. Okay, I only have a couple more minutes before Q&A, so we'll go through this. These are tips for parents whose kids are really struggling during COVID. You know, we're coming up on our second wave, or I guess we're in our second wave. Everybody's kind of tired and sick of this, but you know, these can really be used for kids without OCD too, but let's just go through them. I mean, the first one is to really validate their feelings and concerns, you know, provide realistic assurances, you know, that the best way to stay healthy is to wear a mask, and, you know, in social distancing, and to wash your hands when you come home. You know, you want to make sure that you're like, not like, this is no big deal, or don't worry about it, or you have nothing to worry about. You can validate their feelings and concerns. And like I said, meet it with like realistic assurances. Be aware that times of high stress might mean an increase in or challenging of your child's OCD symptoms. We just said that. Sometimes some people with OCD are flying right through this. Some people are not. And it's okay if there's a little bit of a lapse because your child has contamination fears. It's not a crisis. Let's just get back to the plan. So a setback or relapse is normal. Talk to your child about how the CDC guidelines are going to work with their treatment plan. So, you know, CDC guidelines are washing your hands, you know, for 20 seconds. And so, you know, your OCD ERP plan says something different. Let's talk to your therapist to figure out what we should do, or let's make sure that we're following the CDC guidelines instead of your OCD wanting you to wash another time or for longer. Be mindful that not all COVID-related questions are reassurance. If you have a child that asks for tons of reassurance, you might think any question they ask is reassurance, and that's not necessarily the case. You want to make sure that you're giving them, you know, information, age-appropriate information about, you know, what's going on. You know, you don't want to answer the same question over and over. If they're asking in a pressured way, or you need you to answer it in a specific way, that it's likely reassurance. But otherwise, you want to just be prepared to answer their questions in an age-appropriate way. If your child is obsessing about an uncertain future, like when is this going to end? When are things going to go back to normal? Are we going to be okay? Then you can engage in activities to keep your child in the present moment. So that might mean like a baking activity, a dance party. Let's plan our Halloween, you know, menu for how can we make like spooky spaghetti or fun little cookies. If your child's in treatment, obviously you want to consult with your child's treatment provider, like what changes do we need to make, if any, because of COVID. Definitely, this is probably good for all of us, like limit exposure to media discussing coronavirus. Again, more is not always better. Sometimes there's just a churning of information over and over again with like no value added. We'd want to keep the kids away from that. Like, we are the gatekeepers of information. We also don't necessarily want to like engage the kids with like what we've seen or what we heard or what our own anxieties are. We want to stick to routines, especially if remote learning. My 13-year-old is learning from home, and he has anxiety and OCD, and I'm very strict with our morning routine and our evening routine. There is a morning wake up time. There is showering, brushing teeth, doing their hair, eating breakfast, checking email, and then at night, a similar routine, just to kind of keep things, routines are really important for anybody at any age. So we want to make sure that we build in routines and predictability where we can. Maintain consistency across all caregivers. So parents need to be on the same page. If you're co-parenting, you want to be on the same page. If you have babysitters or grandparents involved, make sure you are on message. You guys are all doing the same thing. Again, you want to manage your own anxiety here. For all the reasons that I said before, kids will absorb your anxiety. They will look to you for clues or cues about how they should be handling new things. And if we want to kind of keep everybody settled, then we want you to be managing your own anxiety. And that might mean, talking to friends about it, or talking to, your spouse about it separate from the kids, or limiting your own media exposure. You want to prioritize self-care. What they always say when you get on a plane, put your mask on first before you put your child's mask on. You can't pour from an empty cup. You really need to make sure, we're in this for the long haul, really want to make sure that you're taking care of yourself, because the better you are, the better your child will be. And exercise. I know it's hard, especially now that the summer's winding down and fall is gearing up, but exercise is good for anxiety. It's good for mental health. And so we really want to make sure that we incorporate exercise into our kids' routine. Some of your children may be in treatment, some of them may not be. When you're thinking about it, you want to notice if your child is distressed or the OCD is interfering and can't be managed at home or school. You might want to refer. The longer the problem goes on, the harder it might be to treat. And the therapy that we would do is called exposure and response prevention, which is part of cognitive behavioral therapy. We sometimes use acceptance and commitment therapy as an adjunctive or like a supersizer of our CBT. And if your child is not interested in treatment, but as parents, you really are interested in figuring out how to sort out and tease out and change the family dynamics, then the SPACE treatment program is a program that parents can do without their children. Okay, so thank you guys very, very much for listening. I know we covered a ton of material and we don't have a ton of time for questions, but maybe we can get right to it and I can answer any ones that come up.
Perfect. Thanks so much for sharing all of that, Denise. This was wonderful. We do have a ton of questions. We've got a little over 10 minutes, so we'll try to get through as many as we can. So one that we saw a lot, as far as reducing accommodations, when should that start? Should it be a gradual exposure to things that are more uncomfortable? Should we start with helping them gain coping skills and then exposure? What does that process look like?
Yeah, I think that it's probably better not to start it at all. But if you find that you're knee deep in it, I think it's time to call a family meeting and say, we cannot do this anymore. And we really want to start to back ourselves out of it. And hopefully the child, you could say like, where do you want to start? Say it's like, Sarah, where do you want to start, Sarah? Like, what things do you think we should start with? And if Sarah is adamant that there is no changing that is going to occur, then you just say to Sarah, like, look, this isn't helping you. Everyone's really angry at each other. It always makes you feel worse. You're not really learning that you can fight OCD on your own. We're going to back out of it. And we'd like for you to be a part of the plan. But if you can't be, then we're going to have to be making decisions without you. I find that gets the kid back involved. And yes, you would start off slow. I would try to start with where the child was willing to start, just because you get better buy-in and then you could grow that from there. use the family contracts like template as a template. And if you are in therapy, then you would do this within therapy. And if you're not in therapy, you could, you as parents could go into therapy just to get some consultation on how to do this. So if you can not even start, that would be great. If you're in it, try to get buy-in from everybody, use the contract as a template and start in one place and grow from there. Does that answer the question?
I think so. Great.
Mm-hmm.
So how does OCD play into eating habits and maybe avoiding a certain ingredient or a certain item beyond taste or health concerns? And has COVID impacted routines around eating in kids with OCD?
Yeah. So yeah, I mean, anything could be impacted by OCD. So kids might not, there's another symptom of OCD called disgust. And so if kids don't like the way something smells or like the way something looks, or it doesn't, it doesn't quite look like it normally does, or it doesn't smell like it normally does, or it doesn't taste like it normally does, they might refuse to eat it. They might think that food got contaminated. Like, Mom, you did not wash your hands after you touched the sink knob. Like, you have chemicals on you. I'm not going to eat this. Or it could be that, you got this at a grocery store, and I'm not sure that you wash your hands, or who can, how do we know that someone with a COVID didn't touch it before, and I'm not going to eat it. So those are ways in which OCD interferes with kids eating. Sometimes kids have a fear of choking. Kids have a fear of throwing up, and so they'll eat very slowly or they'll eat very little. And so that's the way in which it's affected. What were the other parts of the question?
Routines around eating.
Yeah. Well, so there might have to be elaborate hand washing before someone will eat. There might have to be elaborate, like people might all need to shower before that they can eat. There can be elaborate prayer routines before people sit down to eat. People might have to say, like kids who have just right, almost every move they make, they may have to repeat over and over and over. So they may have to sit down in and out of their chair like maybe 10, 15, 20 times before they can eat. So there's all sorts of ways in which eating can be impacted, and family routines, like, mealtime routines can be impacted. Sometimes kids are afraid of, like, they have contamination with other people. Like, I don't want to catch my sister's laziness. And so they might not even be able to sit at the same table as their siblings. So some family members might eat over on the couch, and then other family members are eating at the table. So there's all sorts of ways in which meal times and eating can be impacted by OCD.
Great. And then a few people were asking about if there's a correlation between OCD and autism or Asperger's.
Not really. I mean, I think that they can co-occur. So a lot of times people with Asperger's or autism, I think it's all called autism now, but what we used to call Asperger's, high functioning autism, they may have repetitive behaviors, but those repetitive behaviors, like doing the same thing over and over, serves as like a self-soothing kind of thing. They actually like it. It's enjoyment. It helps them. Or they might perseverate on something like trains. But again, it brings enjoyment to them. It's not something that creates anxiety or fear or distress. So people with autism can look like OCD, but it's the function of the behavior. Like, why are they perseverated? Does it bring them joy or not? Like, why are they doing it over and over? Is it self-soothing, or is it to ward off something bad from happening? But that doesn't mean they can't co-occur. I think but I think the most common co-occurring mental health conditions are depression, ADHD, other anxiety disorders, and tics.
Great. And then here's a really interesting one. As a parent who has OCD but has not noticed any OCD traits with their child, are there any behaviors or tips or tools they can incorporate now that may be beneficial down the road?
So a parent has OCD and they have not seen any OCD behaviors in their kid, and they want to know what they might be able to do prophylactically.
Exactly. Yeah.
So I think that the family culture, so a lot of times people with OCD are like, they avoid all sorts of hard things, not just OCD hard things. So they might avoid, like brushing their teeth at night when they don't want to, or they might avoid talking to a teacher about a bad grade, or they might avoid, telling you what's wrong, like if they're upset about something. And so I think a family culture of approach versus avoid, like we do hard things. We can do hard things. Like really praising bravery based behavior. Like that was so cool how you talked to your friend when you were really mad and you really expressed how you felt. Like, I know that was super hard, but I'm glad you did it. Or, I'm glad that you tried skiing. Like, I know you were kind of worried about it and how it was going to go, but you did it and you were awesome. Like, that's great. So it's a culture in the household of approach versus avoid, reinforcing bravery based decisions, really showing your child that you can sit in discomfort. Like, I have this presentation and I'm kind of anxious, but I'm going to do it anyway, versus, oh my God, I got asked to do a presentation for 800 people. There's no way I'm going to do that. So it's really like the tone, the attitude towards discomfort, the attitude towards hard things. There could be like a family mantra in my house. It's face your fears. It's like face your fears. And so I think those are the kinds of things that can inoculate your child a little bit, or if they start to have OCD behaviors, like they already have some coping strategies for how to deal with hard things.
Great, and we'll do one last one because we're getting close to 3:15. How can school counselors or teachers support students with OCD during COVID? What kind of tools or strategies can they use to ensure that students are successful in school?
Yeah. So I just want to note that on the IOCDF website, we have a whole sub website called Anxiety in the Classroom. And a lot of what's on there, because this is a good question, but it's probably going to take a little while to answer. A lot of what's on there can be used. But again, I think it's sort of like the tips for parents. I think that you want to be able to answer questions, but like in an age appropriate way, straightforward, not lots of fluff. I think you want to demonstrate bravery based behavior. You want to say, like, here's how we're protecting ourselves. Like, we're washing our hands, or, we're wearing our masks, we're 6 feet apart. You want to help kids really just kind of focus on the here and now, the math class, the social studies class, the art project. You want to help them understand like how they can connect with their peers without doing so physically. So kindergartners love to run up and give their teacher hugs, but now we're not doing that. How can you use a wink or like a fist bump, air pump, as a way to connect? As kids get older, I think, like I'm worried a lot too. I'm worried about the teachers, to be perfectly honest with you, being put in situations where they don't really feel all that safe or all that supported. But doing such a great job for their students. Having a classroom motto, we can do hard things. I know in Barnstable, Massachusetts, the teachers union has that motto. I love it so much. But for the older kids, like I'm really worried about the isolation. I'm worried about the teenagers missing out on things, validating their concerns, finding creative ways to commemorate rites of passage. For college kids, again, isolation, help them problem solve ways to connect with their peers, through online, through virtual, getting kids hooked up, with other kinds of support systems if they're really feeling isolated. So every one of these questions I could spend a half an hour answering. So I know I'm speaking fast and spewing out lots of information, but I hope I was able to touch on some of it.
Perfect. And I also just linked the IOCDF website in the chat, and I will include that in the follow-up email as well. But for now, we will wrap there. Thank you, Denise, for such a wonderful presentation. And thank you to everyone who joined us today. I will be in touch with everyone in the next few days to get everyone the recording and a copy of the slides and the link to request that certificate of attendance. Stay safe and healthy and enjoy the rest of your Friday afternoon and weekend. Thanks, everyone.